Pulmonary embolism is the occlusion of the pulmonary arteries by either a blood clot, fat, air, or amniotic fluid. Blood clots typically originate from the deep veins within the leg or pelvis and travel up to the lungs. Fat emboli can come from bone fractures, especially long bones like the femur. They can also come from hip fractures. If a large amount of air is injected through an IV or arterial line, it can cause an air embolism. Finally, if amniotic fluid enters maternal circulation during the time of delivery, an amniotic fluid embolism can occur. As you can see in the image on screen, a clot can originate in the deep veins. These can be known as deep vein thrombosis or DVT. The DVT is going to travel up through circulation and occlude the pulmonary arteries. As the pulmonary arteries are occluded, circulation and perfusion are reduced and lung tissue becomes damaged. In this video, we're going to focus primarily on pulmonary emboli caused by blood clots. Thromboembolism occurs when a clot forms somewhere else in the body and travels. A pulmonary embolism occurs when this clot travels into the lungs and blocks the pulmonary arteries. Let's talk about some of the risk factors for thromboembolism. Recent surgery or trauma of any kind to the body is going to be a risk factor. When we have injury to tissues such as skin or muscle, the body is going to send clotting factors to the site to heal it. It's also going to create more clotting factors in response to this. Having an increase in circulating clotting factors makes the blood more clottable. Inactivity and immobility can also be risk factors for thromboembolism. It's important to note that all of these risk factors are going to be the same for DVT and pulmonary embolism. When clients are inactive or immobile, venous stasis occurs. In venous stasis, the blood is sluggish and not moving as much as it normally would be. If blood is settling, it's going to clot more easily. Pregnancy creates what is known as a hypercoagulable state. Clients who are pregnant are therefore at risk for blood clots. Additionally, if these clients have a cesarean birth, their blood clot risk increases even more. We think about with recent surgery when there's endothelial damage, how the body is going to send clotting factors, and we combine the recent pregnancy creating the coagulable state, we're going to end up with a high risk. If clients have had a DVT before, they're more at risk for having another. Remember, a DVT can travel from the periphery to the lungs and cause pulmonary embolism. In the case of malignancy, certain cancerous tumors can release what are known as procoagulation factors. These are going to increase the clotting factors in the blood and make the blood more likely to clot. Obesity can cause venous pooling, and like I mentioned, when the blood pools, it's going to cause stasis or a lack of movement, which is going to make the blood more likely to clot. Oral contraceptives and hormone therapy increase the risk of blood clots, and smoking can cause endothelial damage. If the endothelium is damaged, the body is going to send clotting factors to try to repair it, and again, you're more likely to have a blood clot. The graphic on the screen is describing something known as Virchow triad. Virchow triad is the three main broad causes of blood clot formation. We have altered blood flow, which would be stasis, endothelial damage, and a hypercoagulable state. All three of these can often result in thrombosis. One of the most common features of a pulmonary embolism is dyspnea. Clients are going to be short of breath because a blood clot is blocking the blood flow to the lungs and decreasing the overall oxygenation of the blood. When perfusion to the lungs is decreased, we're going to have pleuritic chest pain. The pleura is the lining of the lungs, and the decreased blood flow is going to cause an irritation. So when clients breathe in, especially if it's a deep breath, they're going to have a sharp and sudden pain. Because perfusion is decreased, hypoxemia will be common. To compensate for all of this, clients are going to increase their respiratory rate or have tachypnea. Clients may also have a dry cough or eventually begin coughing up blood. If there is damage to the lung tissue from the pulmonary embolism, there's going to be irritation and bleeding at the site, and that's where the blood is going to come from. Finally, if a client's having a massive pulmonary embolism, especially if the entire artery is occluded, they're going to have a feeling of impending doom. They're going to be very anxious. They may have a sudden change in mental status because there's not enough oxygenated blood reaching the brain. These clients will also become hypotensive very quickly. If you think about an artery being completely obstructed, you're going to have a lot less blood flowing and therefore a reduced blood pressure. When we have a decreased blood flow to an area of the lung, it's going to become infarcted. As you can see on the image here, these infarcts are bleeding, and that's why clients cough up blood. Because clots are going to interfere with our circulation, we're going to have a backing up of blood in the lungs. This can cause right-sided heart failure. Pulmonary hypertension and right-sided heart failure is going to coincide with obstructive shock. Like I said earlier, if there's a massive PE and a client has a sudden obstruction in blood flow, they're going to have mental status changes and they're going to become very hypotensive. For clients with a pulmonary embolism, we need to obtain an arterial blood gas for sampling. Initially, these clients are going to experience respiratory alkalosis, but as they begin to tire out and their body begins to give up from all of the extra breathing work, they're going to experience respiratory acidosis. D-dimer is a protein that's created when clots are broken down. If we have elevated D-dimer in the blood, we know that there are active clots somewhere in the body. In terms of imaging, we need to do a CT pulmonary angiogram with IV contrast. This imaging, especially with the contrast, is going to help the healthcare provider visualize the blockage and see the extent of the damage it's causing. Now, for some clients, such as those with renal dysfunction or those who are pregnant, IV contrast may be contraindicated. In this case, we can perform a ventilation perfusion scan or a VQ scan. Clients are going to have normal ventilation, but their perfusion is going to be drastically decreased. Finally, we know that most of these clots are going to originate from lower in the body, so we can use a Doppler or ultrasound to look at the legs and examine for more clots. As the nurse, your primary goal in treating these clients is going to be increasing oxygenation and perfusion. So first, we're going to put the client in a high Fowler position because this is going to help them breathe better. We're also going to administer medications as prescribed. Anticoagulants such as heparin are going to help thin blood. They're going to thin out clots, but also they're going to help blood be thin so it can squeeze by the clots in an obstructed artery. Like we mentioned earlier, these clients may be having pain with breathing, so we can administer analgesics to help with pain. Additionally, analgesics such as morphine are going to decrease the workload of the heart and help increase perfusion. We can also administer supplemental oxygen as needed for the client. Now, we can do all of these supportive measures, but at the end of the day, we still have to get rid of the clot. And there are two major ways we do this. The first is through fibrinolytics or clot busters. TPA is going to be the most common, or through an embolectomy in which the clot is actually physically removed from the body. Embolectomy is typically only going to be done if the PE is very large or occluding multiple different branches of the arteries. All clients who have experienced a PE are going to need to be on long-term oral anticoagulation. Antiplatelet drugs such as apixaban are going to help prevent platelets from sticking together. Warfarin is going to thin our blood. Now, depending on the cause of pulmonary embolism, these clients may not need to be on medication lifelong. But if the pulmonary embolism is related to a clotting disorder, these clients may need to be on medication for the rest of their life to prevent another pulmonary embolism. In the image on the screen, we can see lung tissue and we can see a clot completely occluding one of the vessels here. This is why it is very important that the clot is either removed or broken up. We know that if there is a blood clot here and it is completely blocking the vessel, there's not going to be any blood getting through. Now, unfortunately for some clients, anticoagulants are going to be contraindicated. These can be clients who have a recent GI bleed, hemorrhagic stroke, or a condition such as hemophilia. In these clients, we really can't prevent the clots, but we can catch them. A vena cava filter can be placed to catch the emboli in these clients. As you can see in the image here, we have a deep vein thrombosis that travels through the periphery to the lungs, but it's trapped by the vena cava filter. If we can trap the clot, we can prevent it from getting to the lungs and causing all the issues we talked about earlier.